Welcome to the deep dive. You know that feeling when you're trying to get a handle on complex medical or psychological topics,
hmm
and it just feels like this tidal wave of information?
Totally overwhelming sometimes.
Exactly. So our mission today is really to cut through that noise. We've got this stack of incredibly detailed study notes,
Yeah, really comprehensive stuff.
and we're going to try and distill them down for you, pull out the most, well, surprising, actionable, and truly informative insights.
Think of it as like your shortcut.
Yeah, your express lane to being well-informed.
Absolutely. And this deep dive, it's a unique chance, I think, to grasp some critical knowledge about mental health conditions.
Right.
We're talking intricate thought patterns,
Yeah.
vital medication considerations, the support systems.
All of it.
Yeah, all of it. And it's not just rattling off facts, right?
Yeah.
It's about helping you understand the human experience woven into these conditions.
And trust us, we've got some fascinating ground to cover. We'll be diving deep into schizophrenia, which is often misunderstood,
Yeah.
exploring the progressive nature of dementia, Alzheimer's,
Mhm.
and unearthing some really nuanced aspects of childhood developmental disorders.
Yeah, there's a lot there.
Our goal is to give you those aha moments,
Yeah.
those insights that make things click.
Exactly, those connections.
So let's just jump right in.
Let's do it.
Okay, so starting our journey today with schizophrenia. Right away, patient safety and medication stabilization come to mind, especially in that acute setting. They're foundational.
Absolutely. And when we talk about the immediate signs, we often look at what are called positive symptoms.
Right, positive symptoms, which sounds good, but isn't necessarily.
Exactly. It doesn't mean good.
Right.
It refers to additions to experience things that aren't there for others.
Like hallucinations.
Yeah, hallucinations, seeing or hearing things that aren't real,
Mhm.
and delusions, those fixed false beliefs that are, really hard to shake with reason.
Okay. And medication-wise, haloperidol is a common one, an antipsychotic. But here's a really crucial insight. Long-term use, you have to watch out for tardive dyskinesia.
Oh, absolutely. TD. It's a severe, often irreversible side effect.
Not just a minor tremor, right? It's involuntary movements, face, limbs,
Yeah, shooing motions, tongue thrusting. It can be profoundly distressing.
and it impacts quality of life long after the medication might be stopped. Really underscores that need for careful long-term management.
It really does. And what's fascinating, too, is how schizophrenia shows up in thought patterns.
Okay.
Make grandiose statements. It's more than just, like, boasting.
Right.
It's an extreme exaggeration, driven by their altered reality. A patient might genuinely believe, I am king.
Not trying to impress, but that is the reality.
Exactly. It's skewed.
And then there's the opposite, almost concrete thinking.
Right. A stark contrast to abstract thought. Very literal.
Overemphasis on specific details makes abstract concepts super difficult.
Yeah, so proverbs, metaphors,
Yeah.
they become baffling.
Like the example, nurse asks, "What brought you to the hospital?"
And the patient says, a cab.
Just the literal answer, missing the whole point.
Or the proverb, people in glass houses shouldn't throw stones.
The concrete response is just...
Don't throw stones or the windows will break.
It highlights that fundamental challenge in navigating a world full of nuance. Must be incredibly complex for them.
Absolutely. And that can lead into severely disorganized thinking,
Okay.
where the actual structure and flow of thought are, well, profoundly impaired.
It's not just confusion.
No, it's deeper. Their ability to form logical connections, maintain focus, it's significantly disrupted.
Like that breakfast example.
Oh, yeah. You ask about breakfast, and the response is, well, you read it.
Breakfast is the beginning of the day, but the sun talks sometimes. I used to have eggs, but they fly too fast.
Eggs and birds, birds and bees, they sting like math class. You ever try eating numbers? It's a complete disconnect.
Shows the struggle to maintain a coherent thought makes communication so hard.
Exactly.
So for a nurse encountering that, the strategy isn't about correcting them, right?
No, it's more about connection, empathy. You don't imply they're offensive or wrong.
You sort of accept the blame yourself.
Yeah, you might say something like, I am just having trouble understanding you right now.
Keeps that therapeutic connection open, doesn't alienate them.
Mm-hmm. And if you see someone murmuring, maybe talking to themselves,
What do you do?
you need to directly ask, are you hearing voices?
Address the potential hallucination head on.
Yeah, it opens the door for them to share that experience, which is crucial for assessment and help.
Okay, let's dive deeper into medication side effects.
Yeah.
Chlorpromazine, or Thorazine.
Right, an older antipsychotic.
It's got a range of effects, neurologically, sedation, obviously, but then the big one, extrapyramidal symptoms, EPS,
Yeah, those movement difficulties.
like dystonia, those sudden painful muscle spasms.
Neck, face often. Very distressing. And akathisia, that intense restlessness.
Agonizing, yeah. And we already mentioned the long-term risk, tardive dyskinesia.
Right. And then within those neurological effects, there's the really scary one, neuroleptic malignant syndrome, NMS.
Okay, this isn't just a side effect, this is...
A medical emergency.
Yes.
Full stop. Recognizing this specific cluster of symptoms is literally life or death.
What are the key signs?
Greatly increased muscle rigidity, like stiff as a board, a very high temperature,
Uh-huh.
altered consciousness,
Wow.
and autonomic dysfunction. That means involuntary body functions go haywire.
Like blood pressure, heart rate.
Exactly. Wildly fluctuating BP, rapid heart rate, rapid breathing, sweating, drooling. It's a cascade.
So spotting those subtle shifts early is critical.
Absolutely. Stop the medication immediately. Get medical intervention.
Beyond NMS, chlorpromazine also has cardiovascular risks.
Yeah. Orthostatic hypotension, that dizziness when standing up.
Yeah.
Big fall risk.
Okay.
And QT prolongation on an EKG, which increases the risk of dangerous heart arrhythmias.
And then the more maybe manageable ones, anticholinergic effects.
Right. Dry mouth, constipation, blurred vision, urinary retention.
Yeah.
Uncomfortable, but usually manageable.
And endocrine changes, hyperprolactinemia.
Yeah, that can lead to unexpected things like breast enlargement, even in men, or milk production, menstrual irregularities.
Plus weight gain, which isn't just cosmetic.
No, it's a significant health concern, can lead to metabolic syndrome. And that brings us to the second generation, or atypical antipsychotics.
Right. They generally have less risk of EPS.
Generally, yes, lower risk of those movement disorders.
Yeah.
But they carry their own significant risk, especially for metabolic issues, weight gain, diabetes, high cholesterol.
Can you give some examples?
Sure. Ziprasidone, often used for schizophrenia and bipolar. Quetiapine, Seroquel, that's used for schizophrenia. Bipolar, sometimes added for depression. Olanzapine, Zyprexa, another common one for schizophrenia. Acute mania.
So different drugs, different targets, different side effect profiles.
Exactly. It requires really careful tailoring for each individual patient.
Now, moving beyond the clinic, what about community support? How do we help people thrive outside the hospital?
That's where interventions like PCT come in. Program of Assertive Community Treatment. Or just ACT.
Okay, PCT or ACT, who is this for?
It's specifically designed for the most marginally adjusted patients, those who really struggle with independent living.
So it's intensive.
Very. It's a dedicated team approach, expanded case management, available 24/7.
Wow.
The whole aim is preventing relapse, maximizing social and job functioning, and keeping people in their community.
Instead of cycling through hospitals.
Exactly. And the support is incredibly comprehensive. Help with food, shelter, school, grooming, budgeting, transport, almost every aspect of life.
Does it work?
The data is really strong. These programs significantly reduce hospital admissions, improve quality of life, and a huge focus is on medication adherence, which is key.
It sounds like a complete ecosystem of support.
That's a great way to put it.
Okay, let's transition now. Shifting gears to dementia and Alzheimer's. Starting with something fascinating. Confabulation.
Ah, yes, confabulation. It's a defense mechanism, really.
Picking up stories.
Unconsciously, yeah. To maintain self-esteem when memory fails. It's not lying deliberately.
Like the example the patient who is in bed says.
I discussed politics with President and he took me out to dinner.
Or maybe something less grand.
I spent the weekend with my daughter, even if they haven't seen her.
Their brain is just filling in the blanks.
Trying to protect their sense of self, yeah.
Now, how is that different from delirium?
Ah, crucial distinction. Delirium is always secondary to something else. It's a syndrome, not a disease itself.
Meaning it's potentially reversible.
Exactly. And the causes, especially in older adults, can be surprisingly simple sometimes.
Like what?
A urinary tract infection, a UTI, or just not eating or drinking properly. Dehydration.
Wow. So practical tips for working with someone who is delirious.
Definitely. Always introduce yourself, even if you just saw them. Look them face to face, make sure they have hearing aids, glasses if needed.
Keep explanations simple.
Brief, simple explanations. And consider using a sitter, someone, to stay with them for safety and orientation.
As dementia progresses, other cognitive changes emerge, like apraxia.
Apraxia, yeah. Loss of ability to perform familiar tasks.
Like walking, but also simpler things.
Yeah, dressing. They might understand what they want to do, but can't coordinate the physical steps to do it.
And then there's agnosia,
Agnosia, inability to identify familiar objects or even people.
even their own spouse.
Tragically, yes, sometimes.
Yeah.
And agraphia, inability to read or write.
These losses must make the world incredibly confusing.
Bewildering, yeah. Disconnected from everything familiar.
And in the later stages, the symptoms get even more profound. Hyperorality.
Hyperorality that need to taste, chew, put everything in their mouth, like a toddler exploring, but it can be dangerous if they eat non-food items.
Right. You mentioned pica earlier in the notes.
Exactly, eating non-food items. Also, visual agnosia, seeing but not recognizing, and hypermetamorphosis.
Compulsively touching everything.
Everything in sight.
Okay, let's walk through the stages of Alzheimer's. Really helps to see the progression.
It does. It shows the full impact. So stage 1, mild Alzheimer's. It's often insidious, barely noticeable at first.
How so?
Well, their personality, social behavior might seem okay. People underestimate the decline.
But underneath?
Loss of energy, drive, difficulty learning new things. You might see apathy, depression, mood swings. Daily tasks like shopping, finances get harder, confusion in new places, word-finding issues, maybe suspiciousness, poor judgment.
So it's this slow erosion, even if they seem fine on the surface.
Exactly. Then you move into stage 2, moderate Alzheimer's.
And this is where things really deteriorate.
Significantly, yeah. Can't remember phone numbers, addresses. Memory gaps fluctuate a lot. Hygiene suffers dressing difficulties, resisting bathing.
That must be where apraxia really shows.
Definitely. Mood becomes really labile, rapid shifts. Bursts of paranoia, anger, jealousy, loss of interest in things.
And that catastrophic reaction.
Yes, an excessive response, sometimes physical, to minor things like being asked to shower.
Yeah.
Huge burden for caregivers. Driving becomes dangerous.
Denial might be a factor here, too.
Yeah, denial can be a protective mechanism for them. And you might see psychotic symptoms, hallucinations, paranoid delusions, moments of sadness, too.
Okay. Then stage 3, moderate to severe. This sounds incredibly difficult.
It's devastating for families. At this point, often unable to identify familiar objects or people, severe agnosia.
Can't recognize their spouse.
It can happen. Need repeated instructions for simple tasks, advanced apraxia. Agraphia, incontinence is common. Total care needed.
The world becomes frightening for them.
Very. Agitation, violence, paranoia, delusions are common. Wandering is a huge safety risk. About 60% are at risk.
Wow. And disinhibition.
Yeah, inappropriate behaviors like urinating in public, sexual inappropriateness. It's often at this stage that placement in a skilled nursing facility is considered.
For safety, mostly.
Safety, wandering, danger to self or others, incontinence affecting the household, total dependence.
And finally, stage 4, late Alzheimer's. What does this look like?
This is the most profound stage. Really disconnected. Hyperorality, that constant mouthing, emotions become blunted, visual agnosia, hypermetamorphosis.
Loss of abilities.
Tragically, yes. Loss of ability to talk, eventually to walk. Incontinence, difficulty swallowing, dysphagia. Seizures can occur.
Physical decline, too.
Weight loss, increased sleeping, often just moaning or grunting, can lead to stupor, coma. Death is often from secondary issues, infection, choking.
High risks for
Dehydration, malnutrition, pressure sores, falls. And profoundly distressing for families, they often can't recognize even close relatives.
So given all that, essential care guidelines, safety first, always.
Absolutely paramount.
Yeah.
Setting solid limits is important too.
And always acknowledging their feelings, even if they're being difficult.
Crucial. Even if they're verbally abusive or demanding something impossible, saying, I understand how you feel, can de-escalate things.
Yeah.
Validates their emotion.
And importantly, what not to do.
Don't limit their activity too much. Keep them engaged safely. And try not to let them nap excessively during the day.
Keep that routine.
Yeah, helps manage agitation, maintain sleep cycles.
Okay, medications for dementia. The notes list galantamine, rivastigmine, Donepezil.
Right. Razidine, Exelon, Aricept are the brand names.
But there's a serious warning.
Incredibly important. A black box warning. Increased risk of mortality associated with these drugs in dementia patients.
So they might slow progression somewhat.
For a time, yeah. But not a cure. Use requires careful consideration, weighing risks and benefits, especially later on. Stage 3 often indicates nursing home care might be needed regardless.
Okay, let's pivot now. Final section. Childhood and adolescent disorders. Starting with autism spectrum disorder, ASD.
Right. Core characteristics. Severe social interaction deficits, limited communication skills.
And it's vital to stress. Autism is lifelong. No cure, though therapies help immensely.
And the spectrum is incredibly diverse. not one size fits all.
For some specific symptoms like aggression, risperidone is sometimes used.
Yeah, in some individuals with autism who experience frequent aggression or self-injury, it can help manage those specific, really challenging symptoms, improves quality of life and safety.
And just for context, what does moderate level disability look like, maybe academically or vocationally?
Often means someone might achieve success, say, at a first to third grade academic level.
Okay.
And vocationally, they might be able to perform simpler, often repetitive jobs, grocery bagger, shelter, workshop type roles.
Got it. And briefly, trichotillomania.
That's the clinical term for compulsive hair pulling.
Not just a habit.
No, it's often anxiety related to complex urge causing distress and damage.
Okay, moving to ADHD. Attention deficit hyperactivity disorder. Often impulsive.
Very impulsive, which means safety first is key. They tend to have frequent injuries, the frequent flyers in the ER sometimes. Act before thinking.
What are the core symptoms we look for?
Well, problems with concentration are big. Careless mistakes, difficulty staying focused, easily distracted, seems not to listen, trouble following through on tasks.
Organizational struggles.
Big time. Organizational and time management issues, forgetfulness. They might avoid tasks needing sustained mental effort, misplace things, tend towards messiness.
And the hyperactivity part, how does that present?
In childhood, it's often physical. Fidgeting, squirming, leaving their seat, running or climbing when it's inappropriate, blurting out answers, interrupting, talking excessively.
Does it change in adulthood?
Often shifts, yeah. Less outward running and climbing, more internal restlessness. But the core challenges with attention and executive function usually remain.
Medications for ADHD. There are stimulant and non-stimulant types.
That's right. Two main categories.
How do they differ fundamentally?
Stimulants are usually first line. They work by increasing dopamine and norepinephrine in the brain.
Quick acting.
Yeah, act quickly, often very effective. Examples are methylphenidate-based drugs, Ritalin, Concerta, and amphetamine-based ones, Adderall, Vyvanse.
And non-stimulants.
Used if stimulants don't work or cause bad side effects. They work on norepinephrine or other pathways. Examples include Strattera, which is an SNRI, Intuniv, and Capve, which are alpha-2 agonists.
Do they work differently in terms of timing?
Big difference. Stimulants work right away. Non-stimulants can take several weeks to reach their full effect.
Okay, crucial distinction. Key points for patients or parents managing these meds.
Absolutely. Take stimulants early in the day. Avoids insomnia.
Makes sense.
Monitor closely for side effects. Weight loss, appetite suppression, increased heart rate.
And they're controlled substances.
Yes, high potential for misuse or diversion. Strict adherence to prescriptions is essential. Non-stimulants take weeks, as I said, and always taper off any ADHD med under medical supervision.
Don't stop cold turkey.
Never. Can cause withdrawal or rebound symptoms.
Okay. Separation anxiety disorder. What defines this?
It's a developmentally inappropriate fear or anxiety about separation from an attachment figure.
Beyond what's typical for a young child.
Exactly. Worrying about losing important people, refusing sleepovers, insisting on sleeping near the parent, nightmares about separation.
Physical symptoms, too.
Yeah, somatic complaints like stomach aches when separation is coming up. The key insight is, these symptoms are normal up to about age 1. It's when they persist much longer and interfere with life, like school or socializing, that it's a disorder.
Got it. Then there's conduct disorder, CD. More severe than ODD.
Much more severe than oppositional defiant disorder, yeah.
Yeah.
CD involves a persistent pattern of behavior that violates the rights of others or major societal norms.
Specific criteria needed for diagnosis.
Yes. Things like bullying, initiating fights, using weapons, physical cruelty to people or animals, stealing, fire setting, breaking into buildings, truancy, running away.
It sounds like a significant disregard for rules and others.
It is a profound disregard.
Now let's talk about a therapeutic tool, play therapy, often called the work of childhood.
That's a perfect description. It's not just playing around. It's vital for kids to express things they can't put into words.
How does it work?
It uses toys, puppets, dolls, action figures, and art supplies. Allows children to act out conflicts, feelings, stressful situations.
So they can process things.
Exactly. Work through feelings, and with a therapist's guidance, develop better coping mechanisms. A child might use dolls to show a family fight, giving the therapist insight.
Drawings, too.
Yeah, drawings can be incredibly revealing about inner conflicts, family dynamics, stressors.
And just a practical developmental note, bedwetting in a 3-year-old.
Still perfectly normal. It's a common milestone, resolves at different ages. Nothing to panic about, usually.
Finally, closing this section on an immediate safety point, self-harm.
Absolutely critical protocol. If someone expresses plans to self-harm,
What's the immediate step?
immediately monitor them closely, one-on-one observation if possible, and ask directly about their specific plans.
Don't shy away from the direct question.
No. Assessing the immediacy and lethality of the plan is crucial for intervening and ensuring safety. It can literally save a life.
Wow, okay. What a journey through these conditions. Schizophrenia, dementia, Alzheimer's, childhood disorders.
Yeah, quite a deep dive.
It really feels like these detailed notes give such a unique lens, doesn't it? Moving beyond just the symptoms to the real human impact.
Absolutely. Reflecting on it, understanding these specific cognitive and behavioral patterns, it's profound.
Clinically useful, obviously, but more than that.
Yeah, beyond the clinic, this knowledge genuinely enriches our empathy, I think. Our
Yeah.
ability to connect with just diverse human experiences gives us a clearer picture of what real support looks like.
So as we wrap up, a final thought maybe for you, the listener. How does our understanding of these specific patterns, the concrete thinking, the confabulation, the impulsivity, how does it not only guide professional care, but maybe reshape our everyday interactions?
hmm And how can it help foster a more compassionate society for everyone, no matter what their mental health journey looks like?
Something to think about. Thanks for joining us on the deep dive.